Today's topic was selected because I've been thinking a little bit this week about required fields in electronic medical records, and I thought this would be a really short blog post. I could write it in a few small sentences. Now, of course, 2,600 words later, it ended up being a much larger entity than I wanted to take on initially, but it's a topic which I find very dear to my heart. And so let's delve into figuring out ways we can improve the required fields in electronic health records. The issue is that required fields in electronic health records are clogging up the place all over. They are everywhere from mandatory clinical questions to checkboxes when submitting an EKG order. And the addition of required fields on forms is done with good intent. And the issue, though, is that I'm not convinced it improves patient care all the time. The problem is that it's very easy to make a field mandatory without placing too much thought into why you're doing so. And it seems that no one is taking ownership to go through the medical record and remove required fields that were once created. And as we'll see in this post, a required field may get entered, the data may appear in the medical record, but quite a lot of times that data may actually not be true. So let's go into the first part of this post, which is discussing why is this field required? Well, the field may be required because the doctor said so, or the lawyer said so, or the other doctor said so. Maybe the original paper form that the electronic form is now based off of said so, the department administrator said so, the EHR administrator said so, the hospital said so, the QA team said so, some researcher said they wanted it mandatory, a committee said so, and so, and so, and so. To me, all of these reasons are entirely unsatisfactory for why a field is mandatory. The issue is that required fields can slow down clinical workflows, especially when required fields are not normally part of the standard of care. And for that type of a clinical encounter, like if that required field, for instance, is asking something in addition to what would be typically collected. The other reason we need to be careful is that mandatory or required fields can sometimes generate, as we've discussed, garbage data. And this happens when the only way to process the next step on the form is to complete all the required fields. So if a physician does not have data for that required field, the only way to move forward is to make up something. And this is highly problematic. And the reason that this is concern is because our workflow, now that we've moved into electronic health records, is different from paper forms. When data wasn't available on a paper form in a required field, clinicians just wouldn't fill it in. So, it would become a known culture within an organization of which fields say they're required, but no one actually fills in. The issue is when you move to a computer, if a field is marked required, you cannot bypass it. You can't move on in the user interface without filling out all the required user fields. Now, from my observation of watching students, residents, attendings in dozens of hospitals and countries around the world, when data is not available and the clinician can't move on to the system, essentially someone will make up data to populate that field. And this means that we're populating EHRs with garbage. And, some may disagree and they don't think that this happens or that it's not an issue or that it's not. The people who don't think that garbage data is entering into the EHR are either innocent and naive or suffer from some self-induced blindness, because it is a problem. But the good news is there's some solutions. But I want to just first get back to this paper form issue because it's very important to understand the old workflows. So this was an example of a paper form. You can use this form to fill out all these different types of requests: X-rays, ultrasound, CT, nuclear medicine, MRI. And as you can see, they've got this huge box here in all caps: must complete for all exams. And some self-righteous committee said that this data must be completed for all exams: the patient weight, height, if they're pregnant, and their last known menstrual period. Now, the reality is that nobody actually completes this box for all exams, except for the new medical students. who actually follow the directions on the form. The culture is that no one fills it out unless they think that the information is relevant. So if the patient is particularly large, and this may impact the radiology department, then the user may fill out patient weight. If the patient is at risk for being pregnant, a 30-year-old lady, and they're planning to do a high-risk or an imaging study with a higher dose of radiation, such as an abdominal contrast CT, then the physician will fill out is the patient pregnant part of that form as well. But as you can see, the problem is that we've created a culture where people regularly leave fields on the form blank. Or in the digital version, we've created a culture where people regularly enter garbage information to move on to the next screen. And of course, this is dangerous, and this is how mistakes are made. The problem is that if you always skip the box that says must complete, and you only fill it out when you think it's relevant, there will be times where you forget that the patient probably should have had their pregnancy status confirmed in that box, or if they're nursing, confirmed in that box. But so that's the issue. I kind of view these types of mistakes and errors actually very comparable to alert fatigue or alarm fatigue, where you engage in the same behavior of removing alerts or alarms from the system, such that when there actually is an important alarm, you don't notice it. So in many ways, the ideal system would be one where fields are required only when they actually are important. And this only way to get there is through a constant process of revision of the forms, which are in clinical use, getting feedback on what questions are low value and high value, and weeding out all the low value questions. So let's move on to the next part, which actually proposes 5 different ways and a rational approach to required fields. So the first part of this is to establish a very good reason to make the field required. As we were saying before, a hospital needs to have a very high bar for why the field will be required. For instance, the data field might be mandatory if this is part of a mandatory external report, or if billing cannot proceed without that field being completed, or the field may be absolutely necessary if it is crucial to patient safety being done in that test or order or referral process. If the data is simply nice to have or helpful, it should not be marked as mandatory or as required. I think one of the important things to realize is there's an inverse correlation I've noticed between an increase in the number of fields requested on a particular form and a corresponding decrease in the number of fields a physician actually submits on the form. And so if institutions want users to fill out forms more completely, the solution is to actually simplify and streamline the forms rather than adding more and more questions or making more and more fields mandatory. One caveat: how do we handle questions related to research? And I think hospitals need to approach this very carefully. A large institution will have many concurrent research studies, and each of these has their own laundry list of questions. To add all of their required fields into all the patient's chart would essentially bring an organization to a halt in their ability to provide clinical care. And so required questions for research need to be managed carefully. They need to consider how many additional questions are being added to the standard workflow. And if this does have a quantifiable impact on workflow, perhaps the study should actually reimburse or pay the hospital or clinic to offset the lost productivity from filling out the additional questions. Otherwise, research studies will actually be creating what we'd call in economics externalities in the hospital budgeting of their time and cash. Another way to prevent overloading the hospital forms would be to identify which patients are being sampled for a cohort in a study and to only push questions specific to them, which are required. Okay, so that's the first part, is the way to help improve your required fields in the medical record is to start with a rational approach to really establishing good reasons to why a field is required. We move now on to the second point, which discusses something I'm calling an anticipated expiration date. Every field which is entered into the electronic medical record and specified as required should be given and tracked in some database an anticipated expiration date. So this is the date which is the trigger for whoever created that form or whoever is responsible for managing that form to go back and see, is the question that is compulsory, does it still have to be required? I mean, or even is the question even required anymore? Or can it be potentially removed from that form? Here's some examples of anticipated expiration dates. If a research study is going to end on a particular date, all the questions which were required only as a result of that study should be reverted back to non-required or removed from the forms. If a standard review date, and then the second thought is that anytime a question is set to be required on the form, the hospital should probably have a policy that has a mandatory review period where it will go back to that required field, assess if by making that field required, the task was achieved. If the goal was to streamline the pathology triage process by making these 5 questions mandatory, did that actually streamline the pathology referral process? If it didn't, should those questions actually be reverted back to non-mandatory or even removed? If it did improve the triage process for pathology, then those questions should retain in the form, but they should set yet again another mandatory review date in the future, another anticipated expiration date. But that date perhaps could be much more far in the distance because we know that the first check at least was successful. Another example would be that if a question was tied to the generation of a particular report, if that report is no longer being generated, this should actually act as the trigger for this database to alert the form developer that those questions have reached their anticipated expiration date, meaning that that report, which was the anticipated expiration date, is no longer being generated, and now we need to review these mandatory questions. We move on to the third part now on how to streamline mandatory questions in EHRs, which is we have to actually allow users to skip completing a required field. Yes, you heard that correct. It is very important that a user can opt out and skip any required field. And this may sound a little bit counterintuitive, but it's what would be, I would say, the whole cornerstone of this entire post and this entire recording. This is one of the most important aspects of safe electronic health record form development. Okay? Here's 3 examples on how garbage data enters into the medical record. And if we understand these 3 examples, we can then understand why having an opt-out option would have improved the data quality in all 3 cases. And you can imagine many, many more cases. So the first is that the data requested may honestly not exist. For instance, there may be a required field on a form, and this form is being completed for a man, but that required field is for a data element that only applies to a woman. And so there is no data to fill in on this question field. And so if this is a required field, the only way to proceed would be to make up something, or else essentially you can't submit whatever form or referral or order or whatever you're completing. The second example is that sometimes the work required to obtain the data for the required field is felt not to be justified. And this is quite common. For instance, if a patient if the field was asking for a patient's last known menstrual period, this field may be required in maidens in good. This field may be required, of course, to reduce unnecessary radiation to women who are at risk of pregnancy. However, if you are filling out the form for a 55-year-old lady who's having a low-risk investigation such as a chest x-ray or an uninfused brain CT, it would be considered, a waste of time and overtly a job's worth to ask the patient when their last known menstrual period was, or if they may be nursing. And therefore, in order to get around this, the physician may enter just a random date or use today's date or use perhaps January 1st to enter the date into that field of when the last known menstrual period is, rather than asking the patient. The third example is that at times a physician may forget to collect a required field during the patient encounter. For instance, you may be filling out a pre-MRI checklist as part of the requisition for the MRI, and the physician may have forgotten to fill out one of the fields. So this leaves the physician with three options. The first is to get a hold of the patient. The second would be to delay submitting the requisition until the next time they meet. And the third would be to take a best guess at answering the question. For instance, the clinician might think, I'm fairly certain the patient does not have any cochlear implants. I've known them for 20 or 30 years. I've never heard of them having them. And so they would just select no. And it may seem, though, very dangerous to guess, but the physician may in their mind rationalize it because they know that the patient will be asked the same questions when, another one or two times when they go to actually get their MRI done. And so it's assumed that even if they guess incorrectly on a form, that in the future, this will be rectified. And I would say that from my observations, clinicians have very wide variation in what data they feel they can enter into forms without having directly asked a patient. So let's propose a solution. What if we said that we had an opt-out button, and you could use this button on any of the required field questions. When you select the button, of course, it would also then prompt a drop-down list and free text box where you would record the reason you opted out from entering that data. But this is a much better option than just making up data. So if we go back to example 1, where that form had a question which actually was impossible to apply to our patient. It was a question which only could apply to a woman, and we were filling out that form on a man. The opt-out button would allow the person opting out to select the indication for opting out and then provide feedback directly to the person who created the form about the error in their form. Perfect. We'll move on to example 2. In this case, what we had was a discordance between the administration and the forms teams that had built forms versus the actual clinicians on the ground with what they thought were important questions. And I think it's important for us to be able to track and understand where there is discordance between what administrative levels are asking in required questions and what users are feeling are important required questions. And there is a gap. We need to understand where that is and why it is and how we can bring it together. To pretend that there is no gap and that these differences don't exist is just naive. The third option, the third example we were discussing was one where a clinician was filling out a form and they didn't have 100% certainty about the answer, one of the questions they were filling out. And so they proceeded to take a best guess at completing that question in order to process that order. A better option would be to just be able to select opt-out and then under the indication mention missing at time of form entry. That data was not available at the time of form entry, perhaps because you forgot to ask the patient at the time. Or perhaps you don't have access to their old labs, or you don't have access to the original imaging report. But regardless, it means that you aren't entering information which could be incorrect, which, as I say, is so crucial with EHRs. The data going in has to have high levels of certainty and accuracy in it. And then when the next organization would receive this order or this request, they would see the fields on the request which were not completed. And when they saw the patient, they could ensure that those fields then were updated at that time. Now, of course, if we let users opt out of required fields, we need to track usage of the opt-out feature, right? So it's required for two reasons. One, we need to track the usage of the opt-out feature to know which questions are perhaps needing improvement because people are opting out of them all the time. And second, we also need to track opt-out usage in case certain clinicians are all the time taking this easy way out or using this shortcut. And therefore, you could easily create a system which tracks and monitors opt-out usage. If there were certain outliers from the norm, you could use that fact that they're an outlier as a place to start a discussion. Maybe the clinician who's the outlier is actually correct. Maybe the clinicians who are within the normative range are correct. Perhaps both are. Perhaps both groups are wrong. But you really don't know simply based off of which clinicians are using the opt-out feature more or less. But all that that information can tell you is that you need to have a conversation with them because perhaps their workflow pattern or their patient pattern or their medical practice pattern differs from the other clinicians using that form. But as I say, it's hard to know who's actually correct or incorrect in their usage of that without having a discussion. And so this opt-out feature provides the ability to have this discussion as a starting place. So some questions you may want to be tracking on these automated reports would be which clinicians opt out of fields the most, who are the outliers, which questions are opted out of most frequently. Then you would want to disaggregate that data by particular clinicians, departments, clinics, time of day, other factors, trying to find an explanatory factor on perhaps why a question is more prone to being skipped. And then the third, you may want to understand which questions have had their rate of completion change over time. So perhaps a question is actually becoming no longer useful or valid, and that's why more and more people are skipping it as time progresses. Let's go now to the fourth way which we can improve required fields in electronic health records, which is to show the user the justification for the required field. As you can see in this example on screen, we have a question, and then at the end of it, we have, and let's say that this was a mandatory statement. At the end of it, we have a question mark in a circle, kind of like a help icon. If the user were to click on that help icon, you could imagine that a pop-up appeared where it would show a summary reason of why that question is mandatory. In this case, has the patient ever been treated for rabies is a mandatory question on this form because it's part of a research study, according to the pop-up. If the user wanted to learn more, they could click on the pop-up and it would take them to a detailed explanation page where it would integrate everything that that hospital network knows about that particular required field and why it is mandatory. For instance, which department is responsible for the form in the question, the committee which decided on making it mandatory, the names of the members on that committee at the time and who the head of the committee was, when it was made mandatory, when its anticipated expiration date is for discontinuation, if there should be more explanation. For instance, if it says research study as the summary reason for the question, when you open the detailed explanation page, it would list the actual research study which is linked to this question. If it said that the question is in there for reporting, the detailed explanation page would actually give you the reports which are generated off that question. If this indication was for patient safety, the detailed explanation page would go through explaining exactly how that question improves patient safety and the risks that would be incurred without it. And that page should also explain some of the coding logic, for instance, on who that question is made mandatory for. Is it only mandatory for women over the age of 50 who have never been pregnant? And all this information shouldn't be extra work to compile. Ideally, an institution should be tracking all this in a database, tracking their questions, and in particular, the required field questions. And so it should be very easy to auto-pull this data into the user interface for any users who want to engage with the system and try to understand why a question is mandatory and then provide feedback. But course, I suspect no institutions actually are doing this. But regardless, providing this type of information I think is really useful. One, it increases transparency in the organization. Two, it increases the ability to get good feedback from users. If you provide a user with all of this information about why the field is mandatory, they can review it, they can understand it, and if there are questions, they can know who in the hospital they should talk to for more answers. And in three, in other times, this may help the user understand why something is mandatory, and then by understanding it better, it may in turn make them more compliant to being able to complete that mandatory field. Which brings us to the very last point of how to improve required field questions, which is to be open to feedback. When the user is open to the detailed explanation page for that question, there should be the ability to very easily submit a form right on that page of user feedback, which would go to the desk of the person who's responsible for that required field question in the medical record, and then the user should be able to track as their submitted feedback goes through a process of being reviewed by the question designers and either accepted, incorporated, asked further questions, or declined. But the whole point of this is that getting more user engagement on questionnaires will actually benefit the whole institution. So what are the next steps? Well, I'm actually pretty lucky. I'm working in an organization right now which really cares closely about each question which we ask our patients. And so we're in a review process looking at every required question, trying to determine if the question should be required, why or why not, what are the reasons that it's allowed to be required, and if it should even be on the form or not. And this is, when you think about hospital operations at scale, some of these questions are easily asked hundreds of thousands, sometimes even millions of times annually. And so trying to refine our process is a very reasonable next step. If you know of any hospitals which happen to use any of the techniques suggested above, I would love to learn more about their process. And just two very quick appendages at the end of this post. One is a word on data auto-population. A really important part about having required fields on questionnaires is being able to efficiently auto-populate data from a patient's chart. This will reduce the burden on the user when they're filling in these forms. And we're going to discuss that in an upcoming post in the next 1 or 2 weeks. The second point is just a word on trying to design real-world systems. Some hospital administrators may be surprised to discover that the forms that they created are not completed 100% accurately the way that they were designed. And it is important to realize, though, that the ideal system is a system that works, not a system that remains an ideal. And the workaround discussed in this post suggests a way which is safe and a way which works. It recognizes that the classification of required fields is a dynamic process that requires constant evaluation from users as well as form developers. It recognizes that sometimes the user has more knowledge than the committee that created the form, and other times the user is more lazy than the committee that created the form. And being able to capture this user data about through the field's opt-out button is critical in this process of a self-improving system. So to fail to capture this important user data results in what I would say is our current state of required fields in electronic health systems. This is where we often result in the creation of garbage data, delayed patient care, and an administrative layer which often thinks that everything is going great, that the form completion is awesome, and that our data accuracy is high, when I would argue and challenge many institutions to actually look into their processes of the required fields, because I think their actual findings may be quite different in reality. Well, as I said, this post ended up going significantly longer than the initial 100 to 200 words that I anticipated, but I really enjoyed thinking about this question and think we have a lot of areas we can improve how we're collecting required field information in electronic healthcare records.